Hello, everyone, and welcome to our LIVErNORTH talk in the 2nd of October. It gives me great pleasure to introduce our guest speaker for tonight. It's Professor Prof Mann from the University of Newcastle upon Tyne, who is a liver fibrosis cancer expert, but I'll let him talk to you about that because he knows an awful lot more about it than I do. So it's over to you, Derek.
Thank you very much, John. It's a great pleasure to be here. And what I'm going to tell you about tonight is the research that we've been doing over the past 5 years and are continuing to do, trying to understand how we can improve therapy for hepatocellular carcinoma. And in particular, a type of therapy called immunotherapy, where we try to stimulate the immune system to fight the cancer. And this is a very exciting area of science that actually won the Nobel Prize in 2018 and is now coming into the world of liver cancer, which is getting us all very excited because it is a very promising type of treatment that, rather than giving you a drug, which chemotherapy, instead encourages your own body to fight the tumor. So, John, to get started, I'm going to have to be able to share my screen. I've just tried and it says host disabled participant screen sharing.
Just done it.
So I need you to do that, please. What I'll say in the meantime is that one of the people who've done the lion's share of the work that I'm going to be presenting tonight, later on when I get through the introductions, is a lad called Jack Leslie, who is now, on the basis of the work that I'm presenting, has got himself a lectureship at Newcastle University, and I very much see him as my successor. It's very important to have a succession plan, and Jack's it, and so he's joining us tonight, and he'll be very happy to kind of get involved in answering any questions as well at the end. Right, I should be able to now share, although it still seems to be giving me problems. Let me just see, I seem to have
I've enabled sharing, so
yeah, I don't know what's going on here, John. It's not
okay.
It's not looking great at the moment. It's odd because I've done this only today.
I'll change it back to one participant and see if that helps.
Yeah, try it again and let me give it another go. I guess we should have practiced this, shouldn't we, when we
Yeah, we should have done.
Right, let me try that now.
I hope you're looking at this, Jack, because you're going to have to take over and do this one.
I'm going to have to leave and come back by the looks of it, John.
Okay.
That's what it's telling me.
That's fine.
Usually this is where I'd run round to his office and then fix it all and then make it all work.
Fix it for him, yeah. Well, you've been at Newcastle long, Jack?
Yeah, so I did, well, I came here for my undergraduate degree. So my dad is actually a Geordie and he moved down south.
Yeah.
So basically my whole dad's side of the family live in Fenham.
Right.
So I came to university here because I thought I can get my washing done and I can go around with Nan's for a Sunday dinner.
Right, let me try again. I'm back. Yes,
I just never left.
I can do it now.
Great stuff. Perfect.
I'll be seeing my screen, and I've got to close all these things that I've had to open in order to allow me to share my screen. And I'm going to press on the presentation. Right, can you see that?
Yes, perfect.
Fantastic. Yeah. Okay, so that's the title of the talk: Improving Immunotherapy of Hepatocellular Carcinoma. So why do we need to do this? So first of all, liver cancer is on the rise. There's more of it. not only in other countries, but also in the UK. And I'm going to show you a little bit that later. The most common form is this disease called hepatocellular carcinoma. And that's a cancer that starts with one of the liver cells that I'm sure you've heard about before, called the hepatocyte. It's the main cell type in your liver. So this shows you where we're currently at. This was published in Journal of Hepatology in December 2022, so it's quite up to date. And it's showing you how many people in the world were diagnosed with liver cancer in 2020. So you can see it's getting close to 1 million. And then this is showing you how many people died from liver cancer in the same year. And you can see it's not far off the number that are diagnosed. And that tells you how deadly this cancer is and why we really need to try to do something about it. It's now ranked as the top, amongst the top 3 cancer deaths in 46 countries across the world. And it's really risen to that level in the last few years, and I'll show you why. And the number of people that are going to be diagnosed or dying from this cancer globally is thought to potentially increase by up to 55% in the next 20 years, unless something is done about the causes of the cancer. So this is why it's becoming more common. This shows you a map of the world spread out flat, and it is showing you the amount of NAFLD HCC. So this is fatty liver disease caused, HCC caused by fatty liver disease. And the really kind of striking thing is that the darker the color, the more proportion of liver cancer that's attributed to fatty liver disease. And you can see the UK is really not doing very well at all. Very, very high prevalence, reaching, in terms of NASH itself as the background disease. Now, 2.7 million people in the country have this fatty liver disease, which we think is attributed to the fact that we have a lot of people who are overweight and obese in the country. More than 50% are thought to be overweight or obese, and this is not getting any better. But then I think another factor for our country in particular is the fact that we do like a drink. There's no doubt about that. And that plus the fat in the liver is not a particularly good thing for cancer. And then also we can't rule out the fact that we do have environmental toxins. We are living in a world where there are a lot of pollutants around, and we know that pollutants can affect your liver. So these are probably the reasons why it's on the increase. Now, usually cancer develops on the background of cirrhosis, and I'm sure you've seen these sorts of things before from Quentin Anstey, where he's told you all about steatosis and NASH and how it develops to cirrhosis. And of course, I'm still interested in understanding this process, but it's this development of cancer that's got me really intrigued in the last few years. Normally, when a patient has cirrhosis, they will be tested on a fairly regular basis, a blood test, to kind of find out if maybe there might be a cancer there. And so that's obviously a screening process, which, because you've got cirrhosis, you're more at risk. A worry, though, is that increasingly, and this includes in the UK, we're finding patients who don't have cirrhosis, but develop cancer. And we're not entirely sure why this is. We think it's because the lipid in the liver, the fat, plus the inflammation is triggering mutagenic processes. And I'll explain what they are a little bit later. But suffice to say that there is a new kind of type of liver cancer that's coming on the scene that we cannot screen for. And that's really becoming quite worrying, and particularly because these patients tend to be caught when the cancer is quite advanced, because we're not screening for it. And about 25 per quarter of cancers that develop on the background of fatty liver disease in the UK are found to be this type of cancer that doesn't have cirrhosis in the background. So we do need to be worried about it. So I want to do a little bit about why does HCC develop, and really what it is that years of liver damage set the scene for cells that have mutations in their DNA to accumulate. And as we get older, the ability of our immune system to hunt them down, that's what it does, and kill them, reduces. And this is why liver cancer tends to occur in people who are a bit older. Now, the other thing is that the liver naturally tries to regenerate itself. And you've probably heard this story before. Prometheus, who his father Zeus was tied to a rock, and because he stole fire from the gods and gave it to mankind, which Zeus was not happy about, so he tied him there, and where every day his liver would get pecked by a hawk, and it would regenerate back. So the ancient Greeks knew all about liver regeneration, and we now know, and you'll have heard from people like Derek Mannis, how when he does a big resection of a liver tumor, that the liver grows back again. So that kind of regenerative capacity also impacts on the growth of the tumor, because these cells that carry mutations, the ones that survive and become a tumor, are ones that have a growth advantage, the ones that can take advantage of this regenerative capacity of the liver and grow to become tumors. So what is cancer then? We often don't really kind of go into this when we're talking about research. We assume that people know what it is. So I thought I'd just do a little bit on that. And it goes back a long way. It's probably the most ancient disease that's known to mankind. It was certainly described by Hippocrates, and there is also evidence of it in the ancient Egyptians seem to know about cancers. And Hippocrates described it as veins filled and stretched around like the feet of the animal called a crab. So he actually looked at tumors in patients and he drew them, and he saw all these veins going around a big swelling. And so he called it karkinos, which is the Greek word for cancer. And that's then where we've derived the word cancer from. So it's a very, very old disease. There's nothing new about it. What we tend to think about it, and I had a screen a couple of weeks ago for potential prostate cancer, which thank goodness I don't have, but we almost think of it like an alien invasion. Something's come into our body that is like this alien here, pretty grim looking, and not what we want at all, and certainly doesn't come in peace. And invasion is not a bad idea, a bad word to use, because it's even used in the context of cancers when they become invasive. That means they start to actually grow out from their original point where they develop and spread into a tissue, and can potentially even spread out into other parts of the body. That being called metastasis. But in fact, what we should recognize is that cancer is in fact a part of us. It's not an alien. It's a cell, and it starts generally from a single cell in our body. In the case of HCC, in an hepatocyte that is, in the context of liver disease, being bombarded all the time, and eventually that bombarding of these cells can result in a mutation in the DNA of the cell. And if that mutation is in a gene that either allows the cell to escape from death, so to become immortal, but also to encourage growth, then what happens is that these cells have a growth advantage, particularly in the context of a liver that wants to regenerate, which is what the cirrhotic liver really wants to do. And so then over time, and this takes many, many years to get to this point, a tumor is developed, an HCC. So that's kind of the way it develops. How do we treat liver cancer? I'm not going to go into all of this. It's incredibly complicated, but it shows you the amount of work that has been done, particularly by clinicians, on solving this nasty cancer. But in a nutshell, if you're caught with early stage disease, so up here, very early intermediate stage, usually where there's a single tumor and it's relatively small, then you'll go and see a surgeon like Derek Mann or Steve White, one of these guys, and they will be able to treat that cancer by a surgical technique, which usually either removes the tumor altogether, or there might be a transplant that removes the sick liver and the tumor, or there may be a more targeted therapy, an ablation of the tumor. And these are great treatments. If you are at a more advanced stage where the tumor is bigger, or it's what we call multinodular, where there are multiple tumors in the liver, then that cannot be easily treated by these surgical approaches. And so normally then a patient would advance to systemic treatment, which in the past would have been a chemotherapy, and now is what we're going to talk about tonight, in immunotherapy. Although this looks very good, this early treatment, a problem with it is that it doesn't last forever in every patient. About 50%, sometimes a little bit more, of patients will have their tumor come back again. Sometimes, unfortunately, that can be quite fast. It can be within 2 years. But generally, it's a little bit longer. You can see here that kind of 5 years or more is what we're hoping for. However, when patients do have the cancer come back, then more than often, they need to go into the systemic treatment. So what I'm trying to say is that a patient with liver cancer has a very, very high chance that at some point in their life going forward, they're going to have to go on a systemic therapy. And so this is where we want to make the systemic therapies as effective and preferably as gentle as we possibly can. So this is then the therapies that are offered to patients who need the systemic treatment. And the systemic treatment is aimed at not getting rid of the tumor, but slowing down its growth and progression and stopping it from becoming invasive. So slow down the whole process, but you can't get rid of the tumor necessarily with these treatments. So back in 2007, before 2007, it was really bleak. We basically had nothing at all for this tumor, nothing. But in 2007, we had this drug called sorafenib, which is a chemical drug that kills the tumor by affecting the way that it grows. So that's where we were in 2007. It was then another 10 years before any other drugs were developed, but these were kind of just similar versions that were used in second-line treatment. That's when the sorafenib fails, you would go on to these treatments. And it wasn't until 2018 that another frontline treatment came, lenvatinib, which is another chemical that is used. And back then, it was a case of using these small chemical drugs, and they were used on their own. They were used as single agents. And unfortunately, when you do that, you do get resistance to the drug developing, because tumors, by the time they're quite big, they're tricky to deal with. They can very quickly mutate in response to these chemicals and then not respond to them anymore. And that's why then you've got these secondary treatments that we can put patients on. Then something very exciting happened in 2020, and that's when this thing called immunotherapy that I'm going to tell you about came into being. And also something else came in called combination therapies, where we use more than one agent, and this gives us multiple attacks on the tumor. So we're not just going to one Achilles heel, we're looking at 2, or sometimes in the future, maybe even 3. At the present time, the frontline treatment now is not sorafenib, not lenvatinib. It's this therapy here, atezolizumab and bevacizumab. Okay, so these are the frontline treatments, and this is the immunotherapy that would be offered to a patient if they are suitable for that treatment, and not all are. I won't go into the reasons behind that. That's probably more a talk for Professor Helen Reeves. But I'm going to tell you now about immunotherapy. So, what is it and how does it work? To do that, or rather to explain that, I need to take a step back. And we need to look again at what the tumor is. So this is a nasty looking HCC. And when you look at it grossly like this, there's not a lot you can really tell about it. If you was to make some cuts into this tumor after it's removed and then do some staining and have somebody like Alistair Burt look at it under the microscope, he would see this sort of picture. This is the normal liver around it. Well, it's not normal, it's diseased, which is why it's got a tumor in it, but this is the liver part of it. And this is the tumor here. And you can see lots of little tumor cells in here. And it looks quite homogeneous, looks pretty much the same. But with techniques that we've now developed in the lab, and Jack was one of the key people doing this with a PhD student called Eric, we can now see much deeper into the cancer and get a much more complicated picture of what it looks like. And what you can see is that the tumor is not just composed of tumor cells, the cancer cells. It also has its own immune system. And these green marks here, this is actually lighting up T cells, T lymphocytes, which are an important immune cell that has the capability to kill tumor cells. And in fact, these cells are the cells that go around looking for tumor cells and killing them before a cancer can develop. But then when you've got a cancer, these cells are in there trying their best to kill tumor cells. The white stuff actually goes back to my work on fibrosis, because this is actually extracellular matrix. This is scar tissue. So there's actually a scar within the tumor as well. And that's another place where we might think of treatments in the future by using some of the antifibrotics that have been developed. So that's another exciting area. But what I want to get to across to you here is that the tumor is more than just tumor cells. It also has immune cells. And that gives us one of these Achilles heels that we might be able to start to pick at for getting better therapy. The problem we've got is that although the T cells are there on the site wanting to do the work, they're what we call exhausted. They're not doing the job. They're asleep on the job. And so what we need to do, and what immunotherapy really is, it's like a cup of coffee to wake up the sleeping T cell. So now I'm going to get a little bit sciencey to tell you exactly what immunotherapy is, or the type of immunotherapy that we're using in liver cancer. And I mentioned earlier that the Nobel Prize was awarded for this type of therapy, and it was first started in skin cancer, melanoma, but is now being used in lots of cancers. So what happens with these T cells is that they latch on to tumor cells through a lock and key mechanism. So the tumor cell on its cell surface has proteins that are special to it, that the T cell can hunt out and lock onto. And then the T cell literally spews out chemicals from within, biochemicals from within each cell that are what we call tumoricidal. They kill the tumor cell. For that to happen, the T cell has to be active. It has to be awakened, knowing it needs to do this job. But unfortunately, many times the tumor cell has on its surface another protein called PD-L1, and that recognizes a protein on the surface of the T cell called PD-1, which forms another lock and key. But this is not a good lock and key. This is actually then sending a signal into the T cell to say, don't kill me. Instead, go to sleep. And that's what we call exhausted. And what these chaps came up with that got them the Nobel Prize is they came up with the idea of making antibodies. that will recognize either PD-L1 or PD-1, and by binding to those proteins, effectively prevent the key from going into the lock. And so then leaving the T cell active to kill the tumor cell. And this is absolutely revolutionized cancer therapy. So that all sounds really, really good. And then there was this trial, which was published in the New England Journal of Medicine in 2020, about a combination therapy. This is an antibody that recognizes PD-L1. And then this is an antibody that recognizes signals that make vessels in the tumor. So I mentioned about how, you know, the name cancer has come from these kind of crab-like vessels. So this combination is attacking the tumor in two ways. First of all, it's switching on the T cells, and secondly, it's preventing vessels from being formed. And so then you starve the tumor of oxygen, and tumors are just like us and every tissue in the body. They need oxygen to live. Okay, so this actually then outperformed sorafenib, and that's why it's being used as the frontline treatment. However, you can see down here from the numbers of progression-free survival that the progression-free survival is only giving us a few months better. And then there's another problem with this as well, and that is that less than 30% of patients will respond to this therapy. So as well as the response being less than what we'd like it to be, it's not working for every patient. And there are a number of reasons for that, but one of the key reasons is that the T cell, unfortunately, has not been woken up properly by the coffee. It's still a bit woozy and sleepy. So what Jack's been up to over the last few years to try to find out how we can give another boost and wake up this T cell worker. And to do that, what we've done is to look in this really complicated, what we call tumor microenvironment. And when we look at it deeply, what we find is that there's not just tumor cells and T cells there. There's all sorts of other immune cells inside the tumor. And these immune cells are creating an environment that we call immunosuppressed. You've probably heard of immunosuppression before. It's common to transplantation. You go on immunosuppressant drugs to stop the liver that's been transplanted from being rejected. So you'll be aware of that. Well, actually, your own body can do immunosuppression quite well. And it particularly is the case in a tumor where an immunosuppressed environment is created, which stops the T cell from doing its job. So on top of that kind of, PD-1, PD-L1 lock and key, you've also got these other immune cells that are causing immunosuppression. And one of them has become particularly interesting for us. This cell that I'm pointing at with the arrow, which is called a neutrophil. And Jack and I have both got quite obsessed with these cells. So this is what a neutrophil looks like. This is what it looks like in real life. This is actually a blood smear. And they're these funny looking cells. This is the nucleus of the cell. And they've got this kind of multi-lobed structure. So they really stick out when you look at a blood slide. You can't not see a neutrophil. This is kind of more of a cartoon drawing of them. They are the most abundant white cell in your bloodstream. So about 50 to 70% of the white cells whizzing around in your circulation right now are these guys, these neutrophils. And the reason why you've got so many of them is that they're really important for fighting infections. They are basically the stormtroopers, are the first ones on the site where you've got any sort of infection. And they hunt it down, and they're able to actually use a number of mechanisms to kill those bacteria. In COVID, in fact, neutrophils became a problem. The massive influx of neutrophils into the COVID lung is one of the reasons why patients didn't do so well, because these cells will also produce a lot of toxins if they aren't quickly removed by other cells in the immune system. But for the point of this talk, they will go inside a tumor, and they are one of the key cells for promoting immunosuppression. This is what we've discovered. And this is actually an image, a very high power image using a fancy technology that looks at the tumor microenvironment in very, very great detail. And what you're seeing here in purple are blood vessels inside the tumor. And then in green are the T cells that we want to wake up. And in red are neutrophils. And what you can see, here's a little vessel here, and there's T cells and there's neutrophils, and this is how they've come into the tumor through the vessel. And you can see that the neutrophils in red and the T cells in green are touching each other. And that interaction can go one of two ways. Now, we're in the month of October, where, of course, it's Halloween, and one of the big kind of Halloween horror stories is Dr. Jekyll and Mr. Hyde. And I'm going to use this as kind of a metaphor here, because these cells, these neutrophils, they can be good and they can be bad. I've said that they fight infections. They will also help fight tumors, and they will encourage T cells to fight tumors. But unfortunately, this microenvironment of the tumor kind of makes them turn into more of a Hyde-like character that's actually causing this immunosuppression and preventing the T cells from killing the tumor. So, as you will remember, this transformation of Jekyll to Hyde and Hyde back to Jekyll was triggered by a potion that he would drink. So here is actually a Halloween potion that I pulled off the internet. So could we have a potion for neutrophils that would turn these kind of bad immunosuppressive neutrophils into good stimulators of the T cells? That's what we've been trying to kind of work out. And what we've managed to find is another protein that this time is at the surface of the neutrophil called CXCR2. I won't bother you with what it does on the neutrophil, other than to say that it's one of the proteins that causes them to become immunosuppressive. And there they are inside the tumor expressing the CXCR2. And we know this because this pretty picture here, this flower-like structure, is actually a map of all the cells that you find in a liver cancer. And the petal number 20 is neutrophils. And when we then use a technique to look at the genes that are expressed and the proteins that are expressed in all these cell types, what we find is that the only one in this big kind of brown blob that's expressing CXCR2 is 20, the neutrophils. It's not on the other cell types, maybe a little bit on this number 4, but it's many. And that's really good for a drug target, because it means we can selectively hit these cells if we have a drug that will recognize that CXCR2. And we're really lucky because there is one. It was developed by AstraZeneca, not for cancer, but for treating asthma. I said how in COVID, you got lots of neutrophils in the lung, and that eventually became a problem. Well, actually in asthma, if there's too many neutrophils in your lung, it can cause problems as well. And so this drug was developed to try to treat this neutrophilic version of asthma. It's called AZD5069, and it is a small molecule chemical inhibitor of CXCR2. So it should only affect neutrophils, right? So our potion, we decided, would be this drug from AstraZeneca and an immunotherapy drug, the anti-PD-1, that will prevent that lock and key forming between the T cell and the tumor cell. And what we were asking was, can we what's called repurpose, take a drug that's already was developed for a different disease and repurpose it for liver cancer? and to enhance immunotherapy. And that's why we've got the immunotherapy there. So we're not replacing immunotherapy, we're trying to enhance it. To do that, what Jack did was to make mice fat, because we wanted to do this for fatty liver disease, because I've shown you that that's where most of this cancer is coming from in the UK at least. And then grow a liver cancer inside its fatty liver. And then we treat with either this AZD5069 on its own, or we treat with anti-PD-1 on its own, so immunotherapy on its own, or we've joined them together and we do a combination therapy. And then what we did was we determined the survival of these mice over many, many weeks. And what we found was that with the treatments on their own, the anti-PD-1 and the AZD5069, there was really no difference in survival when you compared these to a mouse that had no treatment at all, the vehicle. But now look at the mice that have been treated with a combination therapy. At what we call the census date, when the vets told us you have to stop the experiment at this point for reasons of veterinary care, 80% of the mice with the tumors were still alive. And we found that they had smaller tumors. Whereas, I say, all of the other mice in the other treatment groups had all died because of the cancer. So this was incredibly exciting. And then I'm not going to bother you too much with this. It looks incredibly complicated here, all these kind of red and blue and pink squares. But in essence, this is a technique that we can use in the lab to work out what the neutrophils look like. Are they good neutrophils that are going to stimulate the immune system to kill the cancer? And that's these ones under this green bar. Or are they bad neutrophils that are going to suppress the immune system? So what these kind of blue and red and pinky dots tell us are the level at which these genes along the bottom, there's a whole list of these genes that are expressed by neutrophils, how much of them is present in the neutrophil in the mouse tumor. So the ones under the green are all genes that make the neutrophils do what we want them to do and stimulate T cells to kill the tumor. The ones under the orange bar are all immunosuppressive genes. So the blue is cold. It means that there's not very much gene expressed. The red is where it's hot. There's lots of the gene expressed. And what you can see is that under the conditions of no treatment or treatment with the individual drugs, most of these genes that are giving us the good neutrophil are predominantly blue. Whereas most of the genes that are giving us the bad immunosuppressive neutrophil are predominantly red. But then look what happens when we do the combination treatment. These turn from blue to red, and these turn from predominantly red to blue. So the potion has, in effect, changed Hyde back to Jekyll. And associated with this, Jack did some beautiful work showing that we'd actually activated T cells in the tumors of these mice. So we can change this microenvironment. That's the really exciting message from this talk. We can turn it from a microenvironment in which the immune system struggles to fight the cancer to an immune system in which it has a much better chance of fighting the cancer. Now, one of the reasons why I got interested in liver cancer is that I want my work to go to the clinic. And I was actually struggling with that in fibrosis, not because of a lack of effort or not because of a lack of interest in clinicians. It's just extremely difficult to treat fibrosis. Cancer is a disease in which there's such an urgency to do something about it because patients have very little time. I've shown you how quickly you can die of this awful cancer. And so it tends to be that clinical trials will get off the ground a little bit easier. And so what we've managed to do is to take this treatment that I've described to you, this AZD5069, and combine it with a drug called durvalumab, which is an immunotherapy drug, and set up a trial called CUBIC that has been run by an oncologist in Glasgow called Jeff Evans. This is a nationwide trial. Newcastle are involved in it. Helen Reeves is going to be recruiting patients to this trial. I'm not going to go through all of this because it's just too complicated and even I don't understand it all. But basically, it's a multi-center study and it has two parts to it. The first part, called phase 1, is to work out the best dose that we can use of this AZD5069. And to do that, we do what's called a dose escalation study, where we give more of the drug to patients as we go through the study. And I'm going to show you that in a minute. In fact, you can see it here. So we're going to have 3 patients initially on dose level 1, 20 milligrams. And then when we know that they're okay and they're not suffering, we go to dose level 2, which is dose level 2, which is 40 milligrams, and then on to 60 milligrams. And finally, we want to go up to 80 milligrams. So then what happens when we're happy that patients are not suffering any serious side effects, and when we got a signal that suggests that the tumor's responding, we're going to go into the second phase, which is efficacy. So Cancer Research UK have funded this, and AstraZeneca are the sponsors. They are providing us with the drug. And I'm pleased to say that it's already started, and we're already up to what we call cohort 3. So we've gone through the first doses of 40 mg and 60 mg, and now 80 milligrams of this drug. And what is really exciting is that we didn't really anticipate seeing any big responses in terms of the tumor shrinking. But in fact, what we found is that as we've gone to 60 milligrams, we have got 2 patients who we call partial responders. So the tumor hasn't gone away completely, but it's reduced by at least 30%. And in fact, Jeff Evans, I had a call with him a couple of days ago, and he told me they've got a patient up there now whose tumor has shrunk by 50%, which is pretty remarkable. So we're now into cohort 3, where we've got another 2 out of the 3 patients we need in this cohort undergoing their first cycle of treatment. And we think, because we've already got 2 partial responders, and Jeff said he thinks he's got a 3rd one here, that we will have enough. We need 3 partial responders in this first phase to be able to go into the bigger phase 2, where we will work out whether this is going to be genuinely a new treatment that's effective for patients. And an important part of this treatment is that before the patients go on to the therapy, they will have a biopsy of their tumor. And then during the treatment, they very kindly agreed to have another biopsy of their tumor. And then this will allow Jack and others working in the lab under his direction to be able to see if we can see the sorts of Jekyll and Hyde changes in the neutrophils in the mouse. Can we see them in the patient tumors, and can we see the T cells becoming activated? And that then tells us that what we found in the mouse is true in the human, and therefore the biology that we've been doing is correct, or well, not correct, but is appropriate to the real cancer in patients. So I'm going to finish there, but by thanking the people that have been involved in this. And I'll begin by thanking Helen Reeves, who's been working on liver cancer for many, many years, more than I have, has really been the person who has put Newcastle at the centre of liver cancer research in the UK. And we are one of the key centres in the UK. And that's thanks to the years of work that Helen's put in and the hard work she puts in with the patients as well. And then Jack, who's done loads of this work that I've described, couldn't have done it without him. Fiona, who's been working with me for years, she came up with me back in 2006 and is the professor of fibrosis biology, but she does a lot of work on cancer. And then Amy is a PhD student, and Eric's a PhD student. Eric does pretty images of the tumor microenvironment. And Dan, who is a clinician, he's done a 3-year PhD with us under Jack's supervision. He's had to go back after finishing his PhD to the clinic. He's currently working down in Durham area, but he's desperate to come back. And he wants to be the successor to Helen. So in the future, it won't be me and Helen. It's going to be Jack and Dan, I hope. But Dan has to get his act together and get another grant to do that. And then I also want to thank the people in Glasgow who've worked with us on this. So Owen Sampson is a very famous cancer scientist. He runs the Beatson Institute in Glasgow. And without Owen, I don't think we would have had the grants from CRUK, because really he gave us that cancer biology credibility when we didn't have it. Leo's a neutrophil expert. Tom is another liver cancer doctor who is very interesting in developing these sorts of treatments. And then Jeff, I mentioned, is a famous oncologist who's leading this work. And we also need to thank AstraZeneca for the drug, and of course the funders, CRUK and the Medical Research Council, and of course Newcastle University, who give us a home to do all this research. So I'll thank you very much for that, and I will stop sharing, and both myself and Jack will be very happy to take any questions. And we can also take questions by email later on. You can either send them directly to us, or I'm sure John will be happy to be the steward of that.
Thank you, Derek. Absolutely fantastic. Wonderful. And thank you so much on behalf of all of the liver patients who will benefit from this in the future. You know, it's so complicated and so much work gone into this. It's mind-blowing. But the results, initial results, look to be absolutely staggering.
Well, I'm thrilled, John, because when I got my first grant from CRUK, it was, I think, God, what year was it, Jack, when we got the first one?
2016, was it 2016?
2016, yeah. I wrote in the grant kind of the aspiration that we would have a clinical trial out of the work, and I expected that to come about now. But in fact, you know, we got the grant into CRUK to do that work 3 years ago. So it was in the middle of the first 5-year grant that we had that we managed to get this treatment to the clinic, which is very, very quick.
It's absolutely fabulous. I mean, it's and to have a 50% improvement in one of the subjects is, so 50% reduction is absolutely staggering.
It is,
you know, it doesn't happen. So
no,
that's great.
You know, even if it only works for that patient, John, that's
that's right. That's right. I did
but
hear
it hasn't. It's worked for 2 others as well, at least out of this first stage.
That's absolutely marvelous. When people say, you know, is it worthwhile, and you're going to extend their lifespan by X days? If you were a billionaire and you were offered 1 extra day's life, you'd just say, well, take all my money and give me another day.
Yep, absolutely, you would, without a doubt. Not only that, but also just to feel a bit better as well and have some
well, that's right, quality of life. That's
hope's
great.
a big word, isn't it?
It is, and for a long time, as long as we've been involved with LIVErNORTH, which was, you know, getting on for 30 years, liver cancer has been, you know, the sword of Damocles. It's hanging over everyone, and you think, oh, they've got liver cancer, that's it, write them off, you know. But it's not that case now. And we had Helen here the other day. She actually came for a coffee, and she was telling us it's very, very exciting. So that's brilliant. So, right, folks, it's time to, if you've got any questions, please put your hand up. If you can either put your real hand up like this is a real hand, or your electronic hand, which is available in the actions at the bottom of your screen. Oh, Yvonne, yes, Yvonne, There you
Hello
go.
there. Hiya. I'm sorry, I can't seem to get my video back on, but can you hear me okay?
Yeah, we
Yes,
can hear you.
absolutely.
All right,
Absolutely.
okay. Just a couple of questions. I mean, that was amazing, John, to listen to that, and thank you so much. I do follow Professor Mann on X, what used to be Twitter anyway.
Yeah.
So seen quite
Oh,
a bit.
blimey, that's an awful platform now, isn't it?
Isn't it terrible?
So much
Isn't
rubbish
it
on there.
Oh, can I just ask you just a couple of things? Is this the same treatment that in the national press? I believe it was the weekend. It was talking about bile duct cancer. Is this what's being used to
No,
treat?
that's well, it's a similar sort of treatment, but it is not the same one. And bile duct cancer is not hepatocellular carcinoma. That's cholangiocarcinoma, which, if anything, is even nastier cancer.
Yeah.
Which we need to do a lot more work on. But no, that's a different type of treatment.
Right. Okay. I was just curious with that because there's been a couple of things nationally talking about treatment of cancer.
Yeah,
One was early prostate cancer being treated and cured within 5 days. I know that obviously that must be something different. But
yeah.
I do have a relative in Edinburgh who had had his kidney removed because of cancer earlier this year, and I suspect that this is what he's on because they have said that he's on some sort of trial, and I'm just wondering if this could be something. It is Edinburgh, and of course it was kidney cancer, but it's in other places now, and
right. So his cancer spread, yeah.
So I just know that he's, in terms of the treatment, he seems to be picking up every single bug that's around. It obviously suppresses your it's an immunosuppressant. So he's feeling pretty lousy because he seems to be picking up everything.
Yes, unfortunately, that is the case with a lot of cancer treatments, is it does leave you open to infections, and it may well be that he is on one of these immunotherapies. So that's not uncommon. However, the cancer docs are really good at treating the infections. So hopefully they get it under control.
Of course, it's things like COVID is such like that.
Absolutely.
Yeah. Oh, thanks, Professor Mann. But thanks again for answering that.
My pleasure.
Thank you.
Okay,
Thank you.
Okay, now we'll have Paul Croft from Barrow, isn't it? Barrow and Furness, you're at, Paul?
Barrow, yes. First and foremost, thank you very much for the presentation. That was amazing. Thanks to everyone involved with the research. John knows, but I'm diagnosed with cirrhosis in my liver.
Right.
But I'm not regular screened. My local hospital, I'm trying to get back to the Freeman, who I was involved with. I was listed for a transplant, but I was fortunate enough to get well enough not to need one.
Right.
Well, he pricked my ears up with the screening for cancer.
Yep.
I'm just not being screened. Would you advise that that's something that I should chase down?
Well, first of all, Paul, I'm not a doctor. I am a scientist. Yeah. So what you need to do is to contact whoever your liver doctor is. Is it Helen Reeves or is it one of the other doctors at the Freeman?
I'm not under a doctor at the Freeman. It is normally Dr. Donnelly.
Right. Well, the best thing to do is to ask whichever doctor it is that you're under about screening for liver cancer. What I will say is that it's still quite rare. Just because if you've got cirrhosis doesn't mean to say you are going to get, a cancer. That's not the case. It's still pretty rare. But by being tested, and it won't be regularly, it won't be kind of weekly, monthly, may not even be yearly, but by getting tested on a reasonably regular basis, then, you know, at least then you've got peace of mind, as does your doctor. So I think it's important you ask about it.
Okay, thank you.
Yeah, it's called the alpha fetoprotein test, and it's
Yeah,
a
I've been
blood test. It's a
taking
it's a
notes.
simple blood test.
Okay, Paul.
Thank you very much.
Yeah.
Thank you.
Okay.
Fine.
Joan, you've got your hand up now. I can't see your picture, of course. Oh, there you came and went. There you go.
And there she is.
Just in the next room. At the beginning, it was quite alarming when you said about fatty liver and how it progresses, and you get these tumours.
Yeah.
Clearly, that doesn't cover everyone.
No.
Everyone with fatty liver will end up with cancer.
No, it's still extremely rare that a tumour will develop, Joan. You know,
right.
This is not the case that if you have fatty liver disease, you are destined to get cancer. It is a risk that you might get one, but the risk is still very, very low. But I think the thing is that on a population level, because there's so much fatty liver disease, that this is why we're seeing more of the tumours. You know, the more people you have with a background disease, then the more you're going to see the tumours, just because that small risk is there. But it is a small risk.
And I don't suppose you know what actually triggers the cancer in some, while it doesn't in others.
We don't really know. No, if we knew that, we would have, you know, a fabulous background in which to start focusing on specific patients. So that is kind of what we need. You know, the alpha fetoprotein test that I mentioned earlier, it does allow you to pick up the tumours when they're quite small, and so then you can give a treatment that in a reasonably high number of patients is curative. But no, we have guesses as to why they develop. We know the biology of it, but we don't know why it happens in some people and not other people. Could be related to the aging of the immune system, which as we get older, you know, in some people is not as fit as others. Could be genetics, that some people are just rigged up so that they're more likely to develop a cancer anyway, and then on the background of the disease that then evolves, and another patient has got a genome or that protects them from cancer. But really, we don't know.
Fascinating subject. So thank you very much.
It is. It really is. Yeah.
Yeah. So Yvonne now again. Can you hear me, Yvonne?
Yes, I can, John. I'm sorry again. I can't start my video, but it was just, and I hope you don't mind me saying this, John, and certainly I hope Professor Mann doesn't mind me saying this, but actually, what Paul has just said there, obviously, I can sort of detect an anxiety there. Can I just say at this point, Paul, that I also have cirrhosis as well, and what is now called MASLD is where my cirrhosis started for, so NFRG. So it's exactly what Prof Mann's just been talking about tonight. However, I am under the care of the Freeman and Prof Anstey, and I get screened. I get a 6 monthly scan, and obviously blood tests, and every couple of years I get a gastroscopy. So obviously the care that I get is first class care. And
yeah, that does sound fantastic.
All I would say, Paul, is you've got to be your own advocate and just fight for it.
Yep.
I hope you don't mind me saying that's Prof Mann.
No, you're absolutely right. Yeah, you've got to get your treatment. You've got to get your screening done, and you're entitled to it.
I think
Paul LIVErNORTH can help with that.
Yeah, we're doing our best. I've been speaking to Paul quite a bit about it. Yes, Paul?
No, I want to say just say thank you. I was just about to say what you said, John, that you've been telling me to bang a drum about it, but quite interestingly, what was just said, you mentioned genetics,
Yeah.
What about hereditary?
It's very, very rare, other than breast cancer as an example, where there's an hereditary basis for it, where there's a risk gene. It's called BRCA1, and in fact, BRCA1 and BRCA2, and you can actually screen for this. And some ladies decide to then have mastectomies to prevent the cancer from developing on the basis of that genetic screening. For liver cancer, we don't think there's anything hereditary in this. It is just a cancer that develops on the background of your liver disease because the liver's poorly, and under those conditions, it's more likely that a cell will just turn funny and start growing in a way that we don't want it to grow. In many ways, it's bad luck.
Yeah. Now, Louise, can you hear me? You'll have to unmute yourself. I'm just asking Louise to unmute. Well, Louise has put something in the chat. I don't know if you've read it, folks. Oh. But the chat, the chat won't be available on the video. So I was going to read it out, but I can't do it without Louise's permission. Okay. So you can read it.
Yes. Can you hear me? Sorry.
Yes, I can, Louise.
Hello.
I'm fine. Can I read your chat out so that the people who watch the video can understand? Yeah, so Louise has said, thank you for a very informative and exciting developments in the treatment of HCC. My dad has been treated at present on sorafenib and is successfully for the past 5 years for advanced HCC. That's hepatocellular cancer, and it's great to see advancements in treatments with immunotherapy. And that's Louise saying thank you for that.
Oh, that's fantastic, Louise. Really great to hear that. I mean, sorafenib is a very good drug. There's no doubt about it. And it is still being used. And I said immunotherapy is not suitable for everybody. And where it isn't, then drugs like sorafenib still have a big part to play in treatment. So that's fantastic to hear about that.
Yeah, no, he was actually very, very lucky that he responded extremely well, and the consultants here are amazed really at his performance.
Brilliant.
It has extended his life really, so we're very thankful for all the research you do.
That's fabulous. Great. Thank you. Thanks for letting us hear about that.
Thanks very much.
Thank you so much. Well, that's it, folks. Thank you for attending and for your questions. No doubt there'll be some more come in by email, and I'll contact Derek and Jack with those questions if we get any.
Please do.
But that's brilliant. So for the LIVErNORTH governors, I'm going to do a doodle poll to arrange a meeting for our next meeting. So that should forewarn you. The rest of us, night. Look after yourselves and take care.
Night, everyone. Bye.
Thank you very much.
Bye.
Bye.